Hey everyone, and welcome. Today, we're diving deep into something pretty incredible. It's the playbook that doctors use to find and remove colon polyps, a procedure that's a lot more complex and fascinating than you might think. So let's get right into it. Right off the bat, let's be clear. This isn't just some minor procedure. We're talking about one of the most powerful cancer prevention tools in all of medicine. According to the top experts in the field, getting these little growths out is a huge part of preventing colorectal cancer. It's not an exaggeration to say this literally saves lives. So what is a polyp anyway? Well, think of it as a small clump of cells that starts growing on the inside lining of your colon. Now, most of them are totally harmless to start. But here's the thing. Some of them have the potential to morph into cancer over time. And that's the whole point of a colonoscopy, not just to find cancer, but to find and get rid of these polyps before they ever get the chance to cause real trouble. Okay, so to really get how this all works, we're going to follow the exact roadmap a doctor uses. We'll start with the problem itself, then we'll walk through what I'm calling their decision map. From there, we'll check out the different tools for small versus large polyps, look at the very latest safety updates, and then we'll wrap it all up with the big takeaway. All right, let's get to the heart of it. When a gastroenterologist finds a polyp during a colonoscopy, what they do next is not a guess. It's a very calculated decision that all starts with asking three really important questions. And those three questions come down to this checklist. First up, size. Simple enough. How big is it? Second, what's its morphology? That's just a fancy word for its shape. Is it flat against the colon wall? Is it raised up? Or does it look kind of like a mushroom on a stalk? And third, and this is the most critical one, are there any signs that it's starting to grow deeper into the wall of the colon? The answers to those questions feed into a decision algorithm. You can think of it like a GPS for the doctor. It tells them exactly which path to take, which tool to use, and which technique is going to be the safest and most effective way to remove that specific polyp. It's our map for this whole explainer. So let's take our first turn on this map, which is also the most common one, how to handle those small polyps, the ones that are less than 10 millimeters in size. For these, the absolute gold standard is something called cold snare polypectomy, or CSP. The key word here is cold. It means the doctor uses a thin wire loop, a snare, to loop around the polyp and slice it off cleanly without using any heat or electrical current. That's a huge deal because it really minimizes the risk of injuring the colon wall. And you can see exactly how it works here. The snare comes out of the end of the scope, and the doctor carefully places it over the polyp, kind of like a tiny lasso. Then they close the loop, capturing the polyp and a little bit of the healthy tissue around it, and slice it right off. It's clean and precise. Now, the official guidelines on this couldn't be any clearer. They say absolutely, you should be using the cold snare for these small polyps. But what's just as important is what they say not to do. You want to avoid using tiny forceps to just pluck at the polyp, because you often leave some behind. And you definitely want to avoid using hot forceps that burn it, because that's just too risky and can damage the tissue sample. The cold snare is just better all around, safer, cleaner, and more complete. Okay, that makes sense for the small ones. But what about when the polyp isn't so small? This is where we head to a different part of our decision map, where the polyps are bigger and the techniques get a lot more advanced. You can see here how the strategy changes with size. For those medium-sized polyps, from 10 to 19 millimeters, doctors switch to a hot snare, which uses heat to both cut and cauterize the tissue. But once you get to 20 millimeters or bigger, the standard of care becomes a much more advanced technique called endoscopic mucosal resection, or EMR. And for the really tough, complex cases, there's an even more specialized procedure called ESD. EMR is such a clever technique. Before trying to remove a big, flat polyp, the doctor actually injects a special fluid underneath it. This lifts the whole thing up, creating this protective cushion of fluid. That little bleb acts as a safety barrier, separating the polyp from the deeper muscle layers of the colon. That makes it so much safer to then go in with the snare and get the whole thing out without causing a deep injury. But check this out. Here's a really interesting exception to the rules. There's a specific kind of flat polyp that has these saw-toothed edges, and it's called a sessile serrated lesion, or SSL. For these, if they don't show any precancerous signs, the recommendation is actually to go back to the cold snare, even if they're big. It's a great example of how the specific type of polyp can be just as important as how big it is. And that brings us to how this field keeps getting better. Because this decision map we're following isn't set in stone. It's always being updated with new research to make things safer and more effective for patients. So let's take a look at what's new in the latest 2024 guidelines. The 2024 update brought in some really key changes. We just talked about that new rule for SSLs. Another big one is a recommendation to use heat to gently treat the edges after a big removal, which helps prevent the polyp from coming back. There's also new guidance on using clips to prevent bleeding and even an official endorsement of a new technique called underwater EMR. I want to zoom in on one of those for a second because it has a massive impact on patient safety. And that's this new idea for preventing bleeding after a large polyp has already been removed. And this chart really tells the whole story. After taking out a big polyp from the right side of the colon, which is a bit trickier, the risk of bleeding later on can be up to 11%. That's not insignificant. But look what happens when the doctor proactively closes that spot with tiny endoscopic clips. The risk absolutely plummets, all the way down to just 3%. That's a huge win for patient safety. So the guideline makes it a super simple 3-part rule of thumb. If the polyp was big, 20 millimeters or more, if it was in the right colon, and if it was taken out with EMR, then the new standard is to close that site with clips before you're done. It's a simple step that makes a major procedure that much safer. Okay, so we've navigated this whole decision map, right? From the tiniest polyps to these big, complex removals and all the new safety rules. What's the one big thing we should take away from all of this? I think this quote from the guideline really says it all. Polypectomy today is based on a selective resection algorithm. Basically, it's not a one-size-fits-all approach. It's personalized medicine, right down to the microscopic level, where every decision is tailored to that specific polyp's size, shape, and location. So if you remember anything, remember this. Getting polyps removed is one of the best things we can do to stop cancer before it even has a chance to start. The right way to do it is carefully chosen for each unique polyp, using that clear decision map. And maybe most importantly, that map is always being updated with the latest science to make things safer and better for everyone. And every piece of this entire decision map we've just explored, it comes straight from the brand new 2024 guidelines published by the European Society of Gastrointestinal Endoscopy. This is the global consensus from the world's leading experts in this field, which really just leaves us with one final question. We now have these incredible tools and super precise guidelines for taking out these growths before they become a problem. So what's next? Will we have AI that helps us predict which polyps are risky even sooner? Or maybe new tech that prevents them from growing at all? The frontier is always pushing forward. Thanks for watching.